Hello to those of you who are tuning in today. My name is Brianna Contreras, and I'm Associate Editor of Managed Healthcare Executive. Today I have Anna Lee, lead author of the abstract, Changes in Cancer Mortality Rates After the Adoption of the Affordable Care Act. Anna will be presenting details of her findings at the American Society of Clinical Oncology, or ASCO's virtual conference, held on May 29th through the 31st. Thanks for being here with us today, Anna.
Thank you for having me. I'm excited to be here.
Thank you, no problem. So to start off, a number of studies have looked at medical expansion, cancer care, and cancer outcomes. What question did your study answer that others haven't?
Well, our study looked at the impact the ACA and specifically Medicaid expansion had on overall cancer-specific mortality. And so since about half of states expanded Medicaid in 2014, we are starting to see differences between those states that did and did not. And so this is really the first study to show that the ACA further decreased cancer mortality, which translates into lives saved. So I think a main benefit of our study is that we used a truly comprehensive database for analysis, and it contains every single US resident who died from cancer.
Ah, okay. Now, any particular reason why yours was the first to look at mortality benefit when that would seem to be one of the most important outcomes to consider?
So a lot of the prior studies have assessed changes in the Affordable Care Act that they made on insurance status and the ability to detect cancers early, timeliness and appropriate access to cancer care. But these are all usually like the first measurable changes after a large national health care policy. So the translation of those benefits to develop into cancer mortality benefit can take years. And so this is likely why no prior study has been able to show this benefit from Medicaid expansion. And our study team has been following cancer mortality changes for many years. And we saw some early changes, but we weren't able to show some definitive benefits until now.
Okay. Now, one of the challenges of measuring the effect of Medicaid expansion is that expansion states are not comparable to the non-expansion states in many respects, different incomes, different ethnic makeup, different disease profiles. So teasing out the effect of Medicaid expansion is difficult. How did your study design and analysis cope with this problem?
Yeah, that's a great question. So first we used age-adjusted cancer mortality, and that controls for the effects of differences in population distributions in different states. So for example, you can imagine a patient who lives in Florida is probably older than a patient who lives in Colorado. But we also compared the change in cancer mortality for each group to itself so that every group acts as its own control. And this type of analysis is important because our group's prior research has shown that patients with cancer who live in non-expanded states are more likely to live in high poverty areas. So you don't want to be comparing this group to a disparate group who may be living in lower poverty areas that have better access to care potentially. So instead of comparing these apples to oranges, for instance, it's really comparing them against themselves through the peri-ACA years so that the mortality gains were put into context for that specific population.
Okay, great. Thank you, Anna. Now next, can you just explain your results?
Sure. So really the main finding of our study is that there was an additional cancer mortality benefit in those states that expanded Medicaid in 2014. But we also found that the baseline cancer mortality rates were better in ACA expansion states and in all subpopulations that we analyzed in those states except for the Black population. Some other findings prior observed findings that we knew, such as the fact that cancer mortality has been falling for many years, and also that disparities exist across groups. So the Black population is the highest cancer mortality rate.
Okay. Now your results show that the cancer mortality benefit of Medicaid expansion was especially pronounced among Hispanics. Any thoughts about the reasons for that?
Yeah, actually we think there's a couple reasons. Number one, the Hispanic population was higher in expansion states compared to non-expansion states. Also at baseline, they have the highest uninsurance rates, potentially because they're undocumented, poor known access to care. So they probably or potentially had the most to gain from Medicaid expansion, but also it should be noted that the data for the Hispanic population had the most variability year to year. So we need better long-term data to show a definitive benefit.
Okay. Now I know you kind of mentioned this a bit before, but
Mhm.
just your thoughts on why results didn't show a cancer mortality benefit for Black Americans.
Yeah. So we thought about this a lot, why we didn't see that. We know that the Black population, you can just see by the slope of the line for cancer mortality in Black patients that they were continuing to have large improvements in mortality, and this probably washed out any potential benefit from the Affordable Care Act. But sadly, even after these gains, their cancer mortality was still worse than white patients. So they were, already so behind that the peri-ACA years we think were catch-up years, but we still have a way to go in terms of improving mortality for these patients.
Okay. Now your results show that there are 785 fewer cancer deaths in expansion states as a result of Medicaid expansion. Did you expect to see a bigger result?
Yeah, at first, well, we didn't really have specific expectations about what number we expected to see, but this number does seem low or not very high when you first, look at it. But we're saying that the policy it saved 800 lives a year, and that can have an impact over time. And additionally, this is not only lives saved, but we didn't really account for patients with cancer whose lives were improved by timely access to care or by having decreased medical bills because they have fewer treatments and the improved treatment options that health insurance can provide. So it should be noted that this estimate is really truly a conservative method of calculating the benefit of the Affordable Care Act. So it is possible that the benefit is even higher.
Okay. Now, lastly, are you going to be using this data to look at any particular cancers?
Yeah, we know that certain cancers can benefit more from more timely access to care or different treatment options. So that is something that we're looking at, and so we're excited to share those results in the coming years.
Okay, great. Um, well, that concludes everything I have, but is there anything you'd like to add, to our viewers or readers of a managed healthcare executive on, your study?
Yeah, well, it's interesting because we're already seeing shifts in the environment with the Affordable Care Act, and many of the provisions that have been put in place have eroded in the past couple of years. So the benefit that we see in our study now could, potentially be impacted by these changes. So it's just important to note that the policy changes that happen on a national level can have a significant impact on every single patient.
Okay, great. Well, thank you so much for your time, Anna. I appreciate,
Thank you
you giving us more of an insight and deeper dive into your study. So I thank you again.
so much.